Ready?
Yep. That one should work as well.
Okay.
Should be good to go.
All right. Well, it is my pleasure to welcome those who are in the auditorium and those who are online to the November lecture in the Vermont Center on Behavior and Health lecture series. And I'm really thrilled to be able to introduce Dr. Shari McKee as this month's invited scholar. And as you can see here on the slide, she'll be speaking to us about women and alcohol. What does stress have to do with it? It sounds like a song title a little bit, but yeah, Shari is definitely one of my favorite investigators. She is professor of psychiatry at the Yale Medical School and director of the Yale Behavioral Pharmacology Laboratory and clinical director of the Forensic Drug Diversion Clinic. And she is a licensed clinical psychologist, so it allows her to do a lot of things. And whenever I have the pleasure of doing one of these introductions, I always learn something about the speaker that I didn't know before. So I didn't realize that Shari did all of her undergraduate and graduate training at the University of Western Ontario in Canada. So that I enjoyed learning about that and learning that Shari was Canadian, and then that put all kinds of other things together about her career and her interests. But I think the clinical degree allows her to do a broad range of things. She directs a translational program of research that focuses on treatment development for addiction disorders, with an emphasis on women and more recently, the criminal justice population, important population. Her work spans clinical, this is what is really attractive to me. It spans clinical trials, behavioral pharmacology, survey research, and epidemiological research to uncover mechanisms underlying poor outcomes and to translate these findings into improved interventions. And if you really want to understand a condition or a disorder, looking at it from all these different directions really can give you a rich understanding, and Shari does that very, very well. She's directed large NIH-funded efforts and focused on developing effective medications for addictive behaviors that, and this is consistent throughout her research, that are responsive to sex differences. She currently leads the Yale score on sex differences in alcohol use disorder, conducting an interdisciplinary translational cross-species research body of research focused on expediting the development of gender-sensitive therapeutics for alcohol use disorder, mentoring junior faculty, and providing a national resource on women and alcohol. So please join me in giving Shari a warm welcome. Shari, thanks for being here.
Thank you for that introduction. I can use this mic, right? Oh. Oh, okay. This one. Okay, great. Is it on? Okay, great. Hey, thank you for that introduction, Steve. Very much appreciate the opportunity to talk with you all today. So just let me get my bearings here. Okay, so as an outline today, I'll first be touching on some facts about alcohol and women, then move into the relationship between stress and alcohol, and then talk about how we might go about treating stress-related drinking. So as we know, gender is, I'm going to be talking both about gender differences and sex differences today. So gender are socially constructed roles, behaviors, expressions, and identities of girls, women, and boys, men, and gender diverse people. whereas sex is biological attributes of humans and animals, including physical features, chromosomes, gene expression, hormones, and anatomy. So when I present preclinical findings, these are sex differences. And most of the human work, at least in alcohol, are a combination of both cis, sex, and gender. And studies of gender diversity with regards to alcohol use are not common, and it's an area that is very understudied at this point in time. So just to give you an example of that, this is a recent review published by Tanda Hughes and her group, looking at structural stigma in alcohol use among sexual and gender minority peoples. Only 11 studies identified, and these studies did not include studies of those who are transgender and non-binary. So a topic of research very much in need of more researchers. So we know that the majority of the US population regularly consumes alcohol, that currently 14% or 33 million meet criteria for an alcohol use disorder. And alcohol use disorders are characterized by a loss of control over drinking, preoccupation with drinking, continued use despite health, job, and interpersonal consequences, and can also demonstrate tolerance and withdrawal. Alcohol is the fourth leading cause of preventable morbidity and mortality in the US, and costing the US economy $249 billion per year in lost productivity and increased healthcare costs. When we talk about what constitutes heavy drinking, one criteria is known as binge drinking, and this is meeting a blood alcohol concentration of 0.08 milligrams percent, typically achieved within a 2-hour period. And that's defined as consuming 4 or more drinks in an episode for women and 5 or more drinks in an episode for a man. And you can see in the little infographic here what constitutes a standard drink. So a can of beer, 1.5 shots of 40% alcohol, or 5 ounces of wine. Now, if you think about how you pour wine at home, how many people truly think they're pouring 5 ounces? So you really need to think about what a standard drink is. So 5 ounces is a little over a half a cup. So it's a very small glass. The NIAAA is currently using the US dietary guidelines for defining risky drinking. So if you're a man consuming more than 2 drinks a day, that's considered risky. And if you're a woman consuming more than 1 drink per day, that is considered risky. We know that binge drinking is highly prevalent, and rates of binge drinking exceed the combined rates of all illicit drugs and non-medication prescription use. And these are, again, US statistics. And sort of, pharmacology 101, that if you have a man and a woman of the same age and the same weight, a woman will achieve a much higher blood alcohol concentration than a man will. And the reason for this is that primarily that women have different body compositions than men. So alcohol is not lipid soluble, meaning it doesn't get dispersed through the fat in your body. And women, unfortunately, have higher fat contents in their body in general than does a man. Women also have less enzyme activity. So alcohol dehydrogenase is the primary metabolite that breaks down alcohol in your body. It's actually pretty toxic. And so women have their alcohol dehydrogenase is 40% less active than compared to a man. And then overall, generally, women's body sizes are smaller. So if you have a smaller woman and a larger man, drinking the same amount of alcohol, the woman is going to achieve, a much higher blood alcohol concentration. And there's also some thought that hormones contribute to alcohol metabolism. That is a big unknown, hasn't been well researched. In fact, very little is known about how hormones influence alcohol drinking. This is a recent publication by Jessica Weaver, University of Kentucky. It was a fairly small pilot study, 21 women. I thought it was pretty ingenious, though. What she did was look at women who were on birth control, where you have certain weeks where you're both on estrogen and progesterone, and then certain weeks where the hormones shut off. And what she found by taking measures of both estradiol and progesterone is that estradiol levels, not progesterone, were positively associated with alcohol use. So I thought this was pretty interesting, and I'm looking forward to looking for more of her future publications. I think this is a really interesting area of work. Historically, we know that men have drank at a higher prevalence than women, and that this gap has been closing. If we look over the prior century to the current, this gap continues to close. And when we look at rates of alcohol use across men and women, we can still see that men are higher. When we look at adults across all of these metrics, whether we're looking at rates of alcohol use disorder or who are engaging in binge drinking, but when we look at samples of adolescents, we see that virtually, if we look at who's consumed in the past month and who's been intoxicated in the past month, that these gaps have essentially disappeared at this point. When we look at what's been happening over time, over the last decade, women have had much larger increases in rates of drinking, binge drinking, and rates of alcohol use disorder compared to men. So this is rates of alcohol use disorder. Women have had a 84% increase relative to a 35% increase in men. And when we dig into this a little bit further, we see that not among the youngest cohort, but among all of the older cohorts, we see a relative 8% increase across all of the older age groups for current drinking, and then also same pattern for binge drinking. This is a study by Gruzza where they looked at several epidemiological data sets and looked for consistent patterns of findings. And what they found was that both the prevalence of alcohol use and binge drinking, greater increases in women, greater increases among certain racial groups, as well as among older individuals. We've been particularly interested in looking at what happens to drinking among older women, and Mackenzie Peltier in my lab has been looking at this with the SWAN data set. And the SWAN is a nice longitudinal data set that captures women for 10 years over the post-menopausal transition. And what she was able to demonstrate with this data is that at certain points during the menopausal transition, that women went from non-problem drinking to problem drinking during this time frame. We're also interested in looking at women who drink because we know that women have exacerbated health risks from drinking in comparison to men. So more likely to experience liver-related injuries, certain cancers. When we look at breast cancer, this is an infographic from the UK that demonstrates a 22% excess risk that increases by 10% for each additional 10 grams of alcohol consumed per day. So for those of you who aren't British, there's about 14 grams in a standard drink. So less than one extra drink a day starts to substantially increase your risk for breast cancer. There's also increased risk for women for alcohol-related cardiovascular conditions, stroke. We know that women who drink experience more neurodegeneration than do men. There's also increased menstrual irregularity, altered hormones, significant pregnancy and perinatal-related consequences. This is an infographic from the National Organization on Fetal Alcohol Syndrome, and FAS continues to be the #1 cause in the US of developmental disabilities. We also know that women who drink are more likely to experience physical and sexual assault, that approximately 50% of these cases involve alcohol consumption by either the victim, the perpetrator, or both. And all of this exacerbated health risk has now, and increased rates of drinking among women have now transitioned into women having greater rates of alcohol-related deaths. So this is a paper that was just published this year, looking at data from 2018 to 2020, demonstrating that women have had an almost 15% increase in alcohol-related mortality during that 3-year time span. In this study, we see that women also have increased rates of ER visits as a result of their drinking, not among the youngest age group, but in 18 plus age groups. The result is pretty consistent. So what drives drinking in women versus men? In this review paper that we published from 2019, we argue that stress is a major driver of drinking for women, and that the pathways are very different for women and men. So for women, the PFC and the amygdala is a key region, interacting with childhood adversity and stress, leading to internalizing disorders such as anxiety and depression, then leading to alcohol use. For males, you see PFC and striatum being important regions, interacting with impulsivity and sensation seeking, then leading to alcohol use. So I'm just going to present a few slides showing the data to support these two pathways. So in this study, they demonstrated that exposure to early life trauma increases the risk for adult onset of alcohol use disorder, with stronger relationships for women versus men. This study didn't look at sex differences, but very clearly showed that as types of childhood maltreatment increase, so do rates of substance use for alcohol as well as other types of substances. There's been a number of preclinical studies as well as neuroimaging studies showing that exposure to child maltreatment or early life stress results in lasting changes to brain anatomy and how your brain functions. And the basic take home from these studies is that early life stress can lead to an inability to manage future stress. This is a longitudinal study from Norway demonstrating that symptoms of anxiety and depression developed during adolescence predict the onset of alcohol use disorder, and that these relationships are stronger for girls than they were for boys. And then looking at why girls are drinking. So this study demonstrated that girls were more likely to drink to cope with symptoms of anxiety and depression, and that this motive as a motive for drinking or drinking to cope is more likely to lead to alcohol use disorder. Conversely, what we see in boys is that boys have stronger associations between their drinking and greater sensation seeking and poor impulse control. Next slide is a neuroimaging study actually conducted at Yale, showing that in looking at men and women, showing that alcohol caused more dopamine release in the ventral striatum in men, and that this relationship was not seen in women. So again, the series of slides I've just shown you supporting, providing data supporting these two pathways. We've looked at some data with the NESARC. This is unpublished, showing that rates of psychiatric comorbidity are higher among women with alcohol use disorder than men. This is a study that was done by Walter Roberts, who's at Yale, and this was a reanalysis of the combined data. So Project Combine was a big medication trial that was run by NIAAA and conducted at several academic sites. What Walter did was to take the data and to look at what baseline and treatment factors predicted treatment outcome, and this is with a machine learning approach. So essentially, the blue bars are unique predictors for men, the red bars are unique predictors for women, and the purple bars are common to both, but differ in their order of importance. So if you look at the top predictors of men, they include aspects of the severity of their alcohol use disorder, whereas top predictors for women included more mental health and disease. So again, data supporting those two pathways I presented earlier. We've also done other epidemiological studies looking at this. So this is with the NISDA data showing that the odds of having an ongoing alcohol use disorder were more prevalent for women that had stress. So women with stress were 4 times more likely to have past-year alcohol use disorder than women without stress. And when you break this down for the number of years that we summarized, you see that ratings of stress or distress, as it is in the NISDA data, are consistently higher in each and every year. We saw this relationship play out over the period of COVID, that we did see that alcohol consumption did increase during the pandemic. And this was a model that George Koob was presenting as to why alcohol consumption increased during COVID, and that stress was a major factor, and that people used alcohol to cope with stress. In this graphic from the McKee Foundation, you see that in relatively large sample of adults that they're reporting very high rates of anxiety and depression, that they're reporting high rates of COVID-related distress, and that they're indicating that their alcohol and their drug use has increased during the period of COVID. So with at least 1 out of 4 reporting binge drinking at least once in the past week, which is a very high rate of binge drinking. This study demonstrated that women were more likely to have a positive association between COVID-related distress and alcohol consumption. Positive relationship for women, you don't see this relationship in men. And in this study, they demonstrated, looking at the amount of consumption, that when you looked at different metrics of alcohol consumption, whether it's frequency, heavy drinking, or consequences, these were all higher among women versus men. So the relationship between stress and drinking in women is well known to the alcohol industry, who have been marketing to women more directly over the last decade or so to relax if they're stressed out and losing it and ready to explode. So within our group, we have this kind of working hypothesis that women are more likely to drink for negative reinforcement, whereas the population of men are more likely to drink for positive reinforcement. And that's not to say that you can't have a man over here who drinks for negative reinforcement and vice versa for a woman, but as a population of women versus men, that we believe that women are more likely to drink for negative reinforcement. Now, I'm sure most of you in the addiction world have seen this heuristic from Koob and Volko of the addiction cycle. The addiction, so involving 3 stages, and we contend that there are sex differences in the application of this heuristic framework, that for women, drinking is best described in the withdrawal negative affect stage, whereas for men, drinking is best described in the binge intoxication stage. The withdrawal negative affect stage is also referred to as the dark side of addiction. That's how Dr. Koob refers to it. and involves drinking motivated by stress and other negative affect states such as dysphoria, anxiety, irritability, and malaise. This is from a review paper that George Koob wrote with Jill Becker, summarizing both the preclinical and the clinical literature, and looking at sex and gender differences, and very clearly showing that negative affect is more of a factor for females versus males in the withdrawal negative affect stage. And that when you look at stress as precipitating relapse, you see that relationship bear out for both humans and animals. So if treatment is going to be effective for women with alcohol use disorder, then treatments need to target factors that underlie drinking in women. And to that end, we have been targeting stress reactivity as a treatment strategy. So currently for alcohol use disorder, there's 3 FDA-approved medications. There's disulfiram, naltrexone, and acamprosate. And it's important to note that these medications were developed exclusively or primarily with samples of men with alcohol use disorder, and none specifically target stress. We know that stress pathophysiology is complex, and there's a lot of really interesting targets to look at from a medication development standpoint. This list is from a paper that Barbara Mason wrote, and where she divided potential targets into brain stress systems and anti-stress systems. And there has been some work focused on these targets. So this is an earlier study by Tracy Simpson, showing that prazosin, which is an alpha-1 adrenergic antagonist, was effective in reducing drinking for those with alcohol use disorder and PTSD. There's since been some more mixed findings with this drug. This is a study of a glucocorticoid receptor antagonist. This was by Barbara Mason's lab, showing some positive initial findings. But again, just like with Tracy Simpson's study that he didn't mention, the subjects are primarily male. So here in Barbara's study, again, about 70% male in the sample, and sex differences were not reported on. Same thing with this study, a small pilot study, not positive findings looking at oxytocin. But again, samples primarily male, sex difference, gender differences not explored in the data. So in my lab, I've been looking at various targets for stress reactivity, so various noradrenergic targets, also have done some work with a kappa antagonist and also glucocorticoids. So for the rest of the talk, I'll be talking about the work with the noradrenergic targets, which are interesting from an addiction standpoint. We know that they are involved in stress-induced relapse to drugs, including alcohol, that they are involved in drug-related reinforcement, so they mediate alcohol-provoked dopamine release in the nucleus accumbens, and they are also involved in improving cognition. So from treating an addiction, sort of an interesting approach and sort of potential multiple ways that the drugs could be improving an addiction treatment. So I'll be specifically talking about guanfacine, which is an alpha-2A noradrenergic agonist. The immediate release formulation is FDA approved for hypertension, and the extended release is approved for ADHD. And we first started looking at guanfacine for tobacco use. So this is a large human laboratory study. There was 100 participants, 50% women. And what we demonstrated was that guanfacine increased the ability to resist smoking following stress for women only, reduced the amount smoked once people decided to start smoking, again, seeing this as a stress effect in women only, and also reduced tobacco craving. We saw a very different pattern for men. We saw that guanfacine attenuated smoking-related reinforcement. So that these reductions in reinforcement were associated with an increased ability to resist smoking. We've also conducted fMRI studies with smokers with guanfacine, and showing that relative to placebo, we see increased activation in areas related to attention and inhibitory control. In collaboration with Kelly Cosgrove, we also did PET neuroimaging studies and demonstrated that guanfacine attenuates dopamine response in extrastriatal regions, and that the largest reduction was in the amygdala. And because Kelly and I shared subjects across our two protocols, we were able to combine data and demonstrated that females with this greater dampening of dopamine release in the amygdala had the greatest ability to resist smoking following stress. So we thought our findings identified that guanfacine-induced attenuation of dopamine release in the amygdala might be an important treatment mechanism for smoking cessation for women. We then further back translated this finding, and this study was led by Marina Peixoto and Jan Manure, and looking at an alpha-2 knockdown in the mouse. So knocked out alpha-2A receptors in the amygdala, and demonstrated that the effect of guanfacine was dependent on having the alpha-2A receptor in the amygdala. We didn't see a sex difference here, though. So then I forward translated these findings into a phase 2 smoking trial for daily smokers, and demonstrated that essentially guanfacine doubles quit rates over the 8-week treatment period, looking at point prevalence outcomes by week. And when we separate this out for men and women, we see that guanfacine is relatively more efficacious in women than it is in men. Effective for both, larger odds ratios for women versus men. So to summarize the tobacco findings, what we're demonstrating is that guanfacine targets stress for women, targets smoking-related reinforcement for men, that the mechanisms appear to be centralized in the amygdala, and that the RCT demonstrated that it was effective for both men and women, but larger effects demonstrated for women. So then we started looking at guanfacine for alcohol use. And as a first pass, we looked at our smoking trial results. We pulled out a subsample that engaged in heavy drinking. And what we were able to demonstrate is that in that subsample, there was 32 of these individuals, that we had significant reductions in the frequency of drinking per week, as well as reductions in the amount of quantity, the quantity they were consuming, and reductions in how often they were engaging in heavy drinking. And that these reductions were associated with plasma medication levels, negatively associated with plasma medication levels. So from there, we then conducted a phase 2 dose response study, human laboratory study, where we either randomized individuals to 3 milligrams a day immediate release guanfacine, or 1.5, or placebo. And then they completed 2 laboratory sessions. So one where we stressed them out, or another session that was more neutral. And we allowed them to ad lib alcohol up to 0.12 grams per deciliter. So overall, we were recruiting a sample that had alcohol use disorder, that were drinking about 5 times per week and engaging in heavy drinking on average for each of their drinking episodes. Safety-wise, the guanfacine was very well tolerated overall. We don't see, this is during the titration phase, which takes 3 weeks for guanfacine. It takes a bit of time to get them up to a full dose. And we don't see any significant differences or any significant really side effects. These were all rated as mild or moderate, or sorry, minimal or mild. So when we start to look at what happened during the human laboratory study, what we found was that the stress effects were particularly pronounced immediately following the stress manipulation. So we used a psychological stress manipulation, and we saw that that immediately that women who were on guanfacine consumed less alcohol than women who were on placebo. And interestingly, we see that women following stress in the placebo group are essentially gulping their drinks. So they're consuming about 10% of their total beverage on that first gulp after stress. You don't see any significant differences for the men, and a similar pattern on alcohol craving. Just like with the tobacco, we see that guanfacine, it seems to be attenuating more reinforcement for men versus women. Now, when we dig into the stress finding a little bit more, it seems that guanfacine is attenuating tonic ratings of stress. So we see this difference right at the start of the lab session. So even before we've applied the stressor, and then when they go through the stress manipulation, we see that these lines remain pretty parallel. So the dotted red line being females on placebo having the highest stress rating. So what we're hypothesizing is that different brain mechanisms modulated by noradrenergic activity are activated by substance use in men and women. So in women, it's the prefrontal cortex, amygdala axis. For men, it's more the mesolimbic dopamine system, and that guanfacine can preferentially target these gender-sensitive systems to improve treatment outcome. So what we're doing now is, as part of the current center, is we're conducting a larger trial, and this is a hybrid laboratory clinical trial design. So we have, after we get them titrated up to steady state on guanfacine, then they complete 3 laboratory sessions. So one is more of a stress manipulation, one is stimulation, one is more of a control session, followed by a 2-hour ad-lib drinking period. And then they move into a 6-week treatment period. So we're able to look at how their behavior in the laboratory is then predictive of their treatment outcome. And across the study, we're looking at a number of mechanisms related to, the focus of our current center. And just to show you what that looks like. So our current center is focused on developing treatments for negative reinforcement drinking, or the dark side of addiction. So across the center, we're focused on various brain structures, neurochemical systems, HPA axis, neuroimmune function, and sex steroid hormones. So to summarize, stress is a major factor in the initiation and maintenance of alcohol use disorder in women. We believe that treatment development for women needs to target stress pathophysiology, that we feel that noradrenergic targets hold promise to target these gender-sensitive systems. And just a plug that all studies need to be powered to examine sex and gender differences, and results need to be separated out for sex and gender. So with that, I want to acknowledge the amazing team that I work with as on this center. Thank the funders of this work, the Office of Research on Women's Health and NIAAA. And a plug, we're always recruiting. So we're recruiting T32 positions, and as part of the center, we also have career development funds to support junior faculty. So with that, I will end and take questions. Thanks.
This one's pretty simple. First off, great presentation. You mentioned that there's 3 drugs that are currently on the market for treating alcohol abuse, but that almost all of the trials were done in men.
Correct.
Do women show worse response rates to those drugs?
So yeah, I can answer that. So the data for naltrexone, so the effect size, you have to remember the effect size for naltrexone is about 0.2. So while it is an effective drug, it's not effective for everybody. Generally speaking, the data have demonstrated about equal efficacy for men and women on naltrexone, but women are more likely to have side effects, including nausea. For a Camperset, same comment that generally speaking, and again, these are all retrospective post hoc analysis of treatment efficacy showing about equal efficacy for a Camperset. And then there is not enough data to make that conclusion for disulfiram.
Yeah, thanks for a great presentation. Two things. Well, one question about two different slides. First, I was struck by the data from the UK showing additional risk with one drink per night for women. I've seen something equivalent in the news, but interesting to see it here. And then thinking about that in terms of your overarching hypothesis, where you showed the two populations, men and women more likely to drink for the dark side of addiction. I'm wondering if you have thoughts on whether the reasons for drinking among women and maybe among men might differ with that initial single drink per night versus for binge drinking or having, 4 or more drinks among women.
Yeah, absolutely. Yeah, I think considering, social context and everything, you're out to dinner, restaurant, have a single drink, that's sort of a different scenario than, coming home and having, a hard day, and drinking an entire bottle of wine, over the course of an evening. I didn't present this data here, but as part of my study, that I'm currently doing during the 6-week treatment phase, we also have a biosensor on the wristband that's primarily tracking heart rate variability, and it's part of a proprietary algorithm which is supposed to be collecting or considered to be sort of an ambulatory measure of stress. So we're collecting stress levels, 24/7, and then associating that with an EMA data collection on their drinking behavior. And what we're finding is that on days, we're finding clearly a strong positive relationship. So the R squared is 0.4 between drinking and ambulatory ratings of the stress measure, which is primarily based on heart rate variability. So yeah, I think, again, I haven't separated out. I just did that overall analysis and I need to separate it out for men and women. But yeah, it's going to be interesting. This is like a lot of data.
There are questions, comments?
So this one kind of has to do with the tobacco data that you're presenting. With the guanfacine reducing drinking generally and then the binge drinking, do you think that has to do with the decreases in the smoking, or there's some sort of reward sensitivity? So the drug itself is overall decreasing sensitivity across the board.
Yeah, that's an excellent question. And it's impossible to disentangle, right? Like, because it could be right. Exactly that the medication is decreasing tobacco, and because tobacco and alcohol are so linked, it could be, then decreasing alcohol. So that was the reason for the follow-up step. So we could recruit people irregardless of their smoking behavior, and then see what the drug's primary effect on alcohol was.
Do you know what the pregnancy labeling is for guanfacine?
Oh, that's an excellent question. I believe, yes, it is something that is, they don't have that category C.
Right, I know.
It would have been a category C if
Okay.
we still had that category.
Yeah, okay. And do you know if anybody has done any work looking at guanfacine in either like a lab type setting or in a trial type setting for pregnancy, either targeting smoking or alcohol
No.
use? Or okay,
No. I don't think it's been done.
Yeah. Thank you.
Yes.
Other questions, comments? Yeah.
Do you have any, or do you know of any data that shows the effects of like different types of stressors, like acute versus chronic stressors, or if that type of thing?
Yeah, that's an excellent question. So that is something, we haven't specifically done. So within our preclinical studies, we're using foot shock as a stressor in our drinking in the dark model for the mice that we're studying. And then on the human side, we're doing a personalized imagery procedure. So the participant meets with a clinical psychologist at an earlier point in time, and we find out details about a recent event that has really stressed them out. And then we develop a first person script for that. And that gets played back to them during the lab session. So that's a really effective procedure in generating, an HPA axis response and increases in systolic, diastolic blood pressure. But we haven't, it's an interesting question. We certainly do look at early life stress. We have a lot of different measures about childhood trauma, but we've not specifically done a study where we've done, say like a pharmacological manipulation, like with yohimbine, which is which has the opposite effect pharmacologically from guanfacine, or done like a cold pressor task or more of a physiological stressor. So we haven't done studies like that.
Thank you for the great review. I feel like clinically, whenever we see research and data that can show us how to craft a treatment plan differently across sex and gender differences, it can be really empowering. And if used incorrectly or if used insensitively, it can further worsen sex and gender stereotypes. So I'm curious if you have observations about how this has been received clinically, just in general, this and your other work, and how to apply it in ways that are welcomed and helpful and don't further engender stereotypes.
Yeah, I think that, just sort of speaking sort of as put my hat on as a clinical director, I don't, what the research we're presenting, I'm presenting here is sort of, not quite ready, for clinical implementation. But that being said, on the clinic side, we're always very sensitive, with regards to trauma and applying trauma-informed care. And I think that's just sort of good general practice, regardless of the sex or gender of the participant sitting in front of you.
I was curious, how far along is guanfacine in terms of FDA, approvals or?
Yeah, guanfacine is approved for the extended release version is the version I'm currently using. It's improved. It's approved for ADHD. It's Intuitive is the medication. So I for this study I've received FDA waivers, exemptions for studying, because I'm personally not interested in indication change. That's for somebody else to do. That's expensive.
Right. Surely, are there?
So our first question that we have online is guanfacine contraindicated for people with chronic medical conditions such as heart, pulmonary, or advanced liver disease?
Yes, it's contraindicated. So guanfacine is also used as an antihypertensive. So it's contraindicated in people who are already taking a blood pressure medication. So that tends to be a major rule out, because a lot of people are already on blood pressure medications.
Awesome. And the other question that we have is asking, have you done any research examining associations between stress recovery and subsequent drinking? I'm wondering if people who have greater difficulty recovering from stress may be more likely to drink problematically.
Oh, that's an interesting question. I haven't done that twist of it, but that's a really interesting thought.
Awesome. And that's what I have online.
Another question, thinking ahead to medication development, do you have any thoughts on medication strategies to improve medication adherence, specifically among women with alcohol use disorder, how this might be applied after some of these trials are conducted?
Yeah, that's always, yeah, I just personally speaking, we test compliance a few different ways. We have a riboflavin marker in the medication, so that allows you to assess compliance in an ongoing way. If you apply a black light to the urine, it will glow if they're taking riboflavin. And then also we always collect plasma medication levels so we can sort of check after the fact that they were compliant with taking medication. But there's all sorts of interesting things people are doing, through phone apps to ensure compliance, like, having people do, record video of them taking their medication every day and texting that along.
I was curious with the titration of guanfacine, what are the issues? How long does it take to get it up, the blood levels up?
Yeah, so we're setting a fairly high level, 6 milligrams per day for the extended release. And we've been titrating over a 3-week period, just because of the orthostatic
Okay.
side
Yeah.
effects. Again, because we do it in such a slow way, we've not had issues. I can't speak if you were to try to compress that window at all.
Other questions, comments? Oh, I have another question. I have not kept track of rates of drinking during pregnancy in the United States.
Yeah.
At different times we've been led to, I think, to the incorrect impression that it wasn't much of a problem. What's your sense of that literature?
Yeah, we've been looking at the NISDA data to sort of address this issue, and I think I had a number in there earlier. So the rate still is currently over 10%.
Wow. Yeah.
It does go down over trimesters, but it's still substantial. I think that that women still haven't gotten the message that no level is safe.
Right.
Just to follow up on that, is that 10% who binge drink, or is that also any drinking?
Any drinking.
Any drinking.
Yes.
Breast cancer data. I had just bumped into that. Someone else, I think, I just bumped into that, or maybe it was Eli. I don't know who it was, but someone else in the audience mentioned it. But I just bumped into that statistic yesterday. So yeah, and
Yeah, the health effects are pretty stunning. I have one of my junior folks. Her name is Boo Boo Benini. She is a hepatologist, and she's been looking at the CDC mortality data and showing that acute alcohol-related liver disease has increased by 40% among young women. So under the age of 35. Wow. It's just, it just sort of, the increase in drinking that we're seeing is really translating into some pretty profound health events.
Right. All the early career people, lots of grant opportunities. Too bad that adverse health effects lead to research opportunities, but we need better clinical interventions and more focus on certain areas. So it's exciting. Any final questions, comments? Then we'll thank you for really an informative talk. We really appreciate it.